IV in place, go ahead and check to see if it's patent.
Alright.
It is a 20 gauge IV. So you guys can see. Okay, so he's cleaned it out. Now he's flushing it. And usually when you flush, make sure you get the air out of your flush first. So you don't flush it into your patient. Any resistance?
Nope.
Any leaking?
Nope.
Does the site look clean, dry, intact?
Looks clean, dry, and intact. Look at this picture.
Good, so our IV is working. It's the right size. Just gonna get that checked out as well. One thing I forgot to mention on here is sometimes the patient does have pre-transfusion medication to be given. Medications which would include, what do you think we'll be giving?
Anticoagulate,
Benadryl would be one of them.
like anticoagulation stuff, possibly.
Not anticoagulation.
Or
So antihistamine Benadryl would probably be one of them. Antifebrile,
yeah.
acetaminophen could be another one. I've had patients who had orders for furosemide, diuretic. In case the patient is food overload, they would be older patients or patients with more comorbidities, like let's say they have issues with potential heart failure. Doctor had ordered me to give furosemide after the first unit before the second one, so I could diurese the patient to make sure they don't get fluid volume overload. Blood is usually spun down and given as packed red blood cells instead of whole blood, but there still is that component of we are giving them volume, which some patients can't tolerate very well.
What about a patient who's diabetic? Would you? Yeah. I'm wondering about like diabetes, blood sugar, and then having to have a blood transfusion. How would that?
It usually doesn't affect the patient too much because you can still check their blood sugar on their finger. You could still give them insulin. You just can't give anything through that same IV line.
Would you have to ever give like any anti-arrhythmic? Oh, yeah, I can't speak. Yeah. Yeah.
For blood transfusion?
Yeah. No.
Not that I'm aware of. I mean, you're thinking about heart patients getting more fluid.
In case you have a reaction.
It was just a question. I wasn't thinking of a backstory.
Well, arrhythmia would be like maybe something's going on with the heart's conduction and whatnot. I'm thinking that patient probably already had like heart conditions to start with, and blood transfusion would be more like, I mean, we're dealing with their circulatory system, but the blood itself that we're giving them should not interfere with the conduction.
Okay.
Does this patient have pre-transfusion medications that we give him now?
Just scheduled.
Scheduled PRN.
What about an anti-emetics?
Antiemetic, unless he's nauseous. So the other lab mentioned that, oh, there's acetaminophen on there. Maybe that's a pre-transfusion medication because we typically could see that order for blood transfusion. But in this case, yeah, for pain or
Can you shut that door?
Yeah.
I'm closer. Okay.
So the acetaminophen in this case not considered a pre-transfusion medication, just because it doesn't say give before transfusion. not specific for that. So he has none, which makes our job easier. If you did have pre-transfusion medications to give and they're orally, typically you would give them at least like half an hour ahead of time, let them have a chance to work, then start your blood transfusion medication.
Mm-hmm.
Did we do all the checks? I think we did all the checks. The orders are in.
To set up the tubing.
Yeah, so you can set up the tubing.
Fine.
Yeah. Okay. So you have your Braun pump, and it's all plugged in already. You have your you got your alcohol. Oh, that's where all of them went. I was wondering why.
They were hiding.
Okay, so you have your tubing, Braun tubing right there. You have your normal saline. So you can go ahead and prime it. So we're setting up our tubing before the blood gets here. So later, at least we don't have to prime it. We don't have to look for it. It's already in the room, ready to go.
Different blood somewhere?
Hmm?
Different blood somewhere?
No, blood is not going to come up yet. We're going to make sure we just set up the saline and the tubing first. So you can use either spike or the normal saline.
Mm-hmm.
So when he grabs his tubing from the bag, basically, first thing he does, like as with other tubing, clamp everything.
I claimed it before you said that. All good.
Okay.
Parasites inside of You can put it around your neck too.
You know what?
It's cheesecake from the hospital cafeteria. The parasites inside of cheesecake from the hospital cafeteria. It's gonna be bad, it's so good. I'm gonna clean my uniform and get some. Get till next Tuesday. Can't wait till Wednesday. I'm all for your cheesecake. The cheesecake was foul. So crust was good, so I just the breakfast burrito was good. Big back time didn't say so when I was there. I can't help myself.
It's been a few weeks since I've done this.
2 days in a row is diabolical. I just hate driving all the way down there. That's brutal. I was kind of tired because we're having a CNA, so the patients were like starved for attention. You miss Kafka. Put the blinds up. Okay. No, I'm not like that. Okay. Go ahead and close them and turn the light on. Okay. 2 more apple juices and another sandwich. Captain, your blood sugar's 140. You haven't got your insulin yet. I said.
This one's
Girl's like, oh, I'm so tired. She's
this
always
one.
I just feel like for a lot of the patients, like they had so many issues underlying that weren't even diagnosed. So, like, I had a 21-year-old patient who had acute weakness starting Wednesday. She like literally couldn't stand. Before that, it was normal. They wrote it off as like depressed. I'm like, yeah, like okay, she stopped taking Lexapro like 2 months ago, so like maybe paresthesia.
Oh, that's
She was
good.
tingling, you know.
It should have been great.
she might not be able to stay.
Sudden onset of general is what you said.
It's a little slower from
Yeah.
filter. I know, I was looking through all the
That's
speeds and stuff.
so
So right here, just goes really slow.
This is
That's
open.
open. That's open. This
That's
is open.
open. That's open.
Green
Maybe
boy
push-
here's unclear.
I'm gonna
Seems like her whole
push this. Oops.
Yeah, it's close to what it says.
Sometimes because it's used already.
Should probably line it up here.
Hopefully next time she comes to the hospital, she goes to different.
And she has the insurance.
It's either that or she's.
I think that's a problem.
Alright, that should be good. Still set.
Yeah, nobody's like, oh, let's go to Paradise Valley Hospital. He's sick. But they probably also don't know any different with healthcare. You know what I mean?
Fill up the filter.
Fine. It's okay. You're right.
So for that shield, we have one because the floor that we are on.
You do want a small gap though, because then you can see the blood drip in there. I mean, this blood is not that dark of a color, but real blood, if you don't have a gap,
The nurse's
So
station
it's
is
right on top of them.
yeah.
I was like, oh, this is probably better. And then they have like obviously the other one that's behind the door because it's like
There we go. And then there is air down here, you pick up the air. So you have like a tactic to get the air up, and then like the squeeze it out to the top.
since there was 15 patients, like 9 of them were incarceration. So like they only have like 6 patients or 7 patients to go between. And the downstairs each has like 2. There's one of them. One of them is
Yay, okay.
I called it.
No, that was the most exciting thing that happened.
As soon as they stopped giving him his Ativan,
Oh,
Alright.
He woke up, he was like,
I have recap this.
he was walking.
As long as it don't touch the inside here.
security wasn't doing that good.
So at this point, now that it's primed with the normal saline, you want to clamp up the saline.
he was talking to the nurse and like security was just like.
So this part's very important. After he primes the tubing with normal saline, he has to clamp it again. So we're not going to use the normal saline again. So we want to make sure it's clamped. If we left it unclamped, what would happen? Yeah, it could keep running. And later, if we spike the blood bag, it goes into there, and you see 2 bags of blood instead of 1. So that would be a lot of volume for your patient. No, so one thing I really doc students on for test outs, make sure you clamp this. Okay? We prime, clamp, need to clamp. At this point in time, you are allowed to attach this to your patient and keep it KVO, such as at a rate of 5 or 10. Or you could just turn this off and wait until the blood comes. Up to you.
Okay.
Or
I hear beeping.
do you want to connect it or do you want to just leave it?
Well, it depends. Like, is this patient not technically voting?
No.
No, okay.
No, his vitals are within normal limits.
I'll just leave it here.
Okay, we'll leave it. Go ahead and turn your pump off. Okay, so at this point, he basically did everything on the checklist already. He is ready to give his blood. So he's gonna send a runner. To his runner, he will give the ticket for the blood. Usually it comes pink like this, but every facility is a little bit different. On the pink ticket, he has written the blood bank identification number BB1927. So make sure it matches his blood bank ID. Yeah?
BB1927.
Okay. Correct patient, correct birthday,
This
correct.
is leader 118.
And we're sending for blood.
This is for blood. It's cross match type. Yeah.
Okay. So he's verified his ticket is correct. He will send a runner. Who can his runner be? CNA. Who else?
Another nurse.
Another nurse. Who else?
Resource centers.
Resource nurse. Who else?
Lab tech.
Charge. Lab tech.
Could be sent in like the tubes, mag tubes. could be sent in like a pneumatic tube if your hospital has one.
You can't, just because the other person does have to verify before they bring it back.
Okay.
And you can't have blood out of hand, right? If we're getting arrows messing in someone's hand to verify that it's not, you can't set it down in school.
Yeah, well, you do need a second person to verify. So the runner can just be about anyone. Hospital volunteer, retired volunteer, sure, send them up. Doesn't matter if they have medical experience or not. Secretary, she has time, send her, send her. Student nurse, you guys are twiddling your thumbs and, you're looking for something to do, you can go get blood, okay? So it doesn't have to be someone who's a nurse, it doesn't have to be your resource, it doesn't have to be your chart, it doesn't have to be you, okay? So whoever is qualified to work in the hospital can definitely get the blood for you. So who would your runner be? You can choose.
CNA busy?
We're all busy.
Who's your student nurse for the day? You
Who's my
can
student
pick
nurse for
someone.
the day? Sarah will be my student nurse for the day.
Okay.
That's your most proximity. And you go down to the blood bank and get
What's your process?
blood for this patient.
Yeah, sure.
Okay, so
So do I confirm everything is verified and checked out?
Mhm.
And where's the blood bank?
blood bank is over here. So at the blood bank, at the blood. I'm standing here. There's no demanding. Okay. All right. So I'm looking out through the window. Hello. Are you coming to pick up the blood?
Yes, I do have the slip here for
Perfect.
blood pickup.
Go ahead and put gloves on.
I've been verified by the nurse.
Excellent, excellent. So I can't just hand it to her, okay? So the blood tech is going to verify everything before I hand it over. She doesn't have to know about blood compatibility. That's not her role. All she needs to do is make sure everything matches on here as I read it off. So this looks at the correct blood that I'm gonna send up, but just as I read it off, just make sure that's everything on the ticket, okay? Your patient's name is Justin Fleeter. Medical record number is 567800. Patient's birthday is January 18th, XX. Let's see, I'm gonna verify that the product unit is 0053274. Okay, so your patient is AB positive. I'm giving you, this is B negative blood, and blood bank number BB1927. Okay, so this is, see, red blood cells I'm giving you. Okay, 300 milliliters. Not expired yet. It doesn't expire until January 1st. XX. Okay, and let's see. That might be. Yeah, that's everything I have to do. Okay, all looks good. It matches on here. So you'll sign off, I'll sign off. And I'll keep the ticket. And what you do is take this, and this is your blood, along with, you're gonna give to the nurse the documentation. So here is his pre-transfusion checklist that he has to verify with the second nurse. These are areas where he can check vital signs. Okay. You won't need this one unless the patient has a transfusion reaction. So you give that to him. So basically, the runner gives the blood directly to the nurse. She doesn't hand it off to the charge, she doesn't put it in the room. It has to go directly into Josh's hands again. Okay. So it's all set here. I keep the ticket.
Back on a unit.
Alright.
I got your blood, Josh.
Thank you, Sarami.
Thank you.
No problem. Perfect.
All right, Josh. Who is going to be your secondary nurse? by looking at that pre-transfusion checklist. Both of you need to verify with that.
Triple this real quick. Okay. So, word. Name Justin Bleed.
Justin Leader,
MRN 567800.
567800,
118XX for birthday.
118XX.
The patient's blood type is AB positive.
I have AB positive.
Product is B negative.
And you verify by looking at the bag.
Okay.
Okay, is that compatible?
No. Oh, yes. Sorry. Yes.
Okay, alright,
Yes.
good, so it is compatible because patient's blood type is, he's a universal
AB
recipient.
positive, yeah. Do we also read out the unit number as well?
Go off of the pre-transfusion checklist, and you're just doing everything on
This one?
here.
Okay.
So we cross-match the blood product, with the blood bank from attached, to the units of the cell. Okay, and then physician ordered patient armband.
Yes, we have that right here.
Okay, so you have to, now one person's looking at the patient armband and one person's looking at the blood. Okay, so if Nicole's holding the blood, she has to have gloves on.
Hand sanitizer.
So you can't both just be like looking back and forth. One person specifically looking at the patient, one person specifically looking at the blood bag.
Oh,
And you
okay.
have to spell out his name, you know, match the birthday, and you ask him all of that, what's your name, what's your birthday, then you spell out his name letter by letter per the transfusion checklist.
Okay. Justin, Justin, Bleeder, Bleder. Birthday's 118XX. And medical record number is 567800. And the blood band is 1927.
BB19.
BB1927.
Does everything match?
Mm-hmm. Correct.
What else?
And then the physician order present. With the blood component ordered.
Here's consent as well. It's the order.
Right here.
Yeah.
Transfusion, 1 unit of blood.
Over 3 hours.
Okay, unit of 1.
One.
And then product is the
Red blood cells.
That's checked off. And then consent for transfusion is signed in the chart.
Yeah, that's consent to blood.
Okay. And then spell aloud and verify the patient's name and hospital number on cross match tag, matched with the patient's ID bracelet.
We did that.
Okay. Did we also? We already did the cross match for the blood, and then verify the donor's number on tag and product batch. I think that's this part.
Is that the BB1927?
Yeah.
Okay, yeah, you did that.
And then, can you verify that the product's not expired?
Product is not expired. 1211XX. Yeah, that's blood loss forever.
Okay.
Alright.
And then, visually inspect the blood for discoloration or clumping.
That's some Hawaiian punch. Yep.
Okay.
Good.
It's been checked off.
Okay, good, so now he can hang the blood. And Nicole can't leave until she verifies he hangs at the correct rate. So go ahead, hang the blood. What rate do we wanna hang the blood at?
Oh, sorry. 1 unit over 3 hours.
So initially though, usually it's hung at a different rate. Okay? initially you want to make sure the patient doesn't have a transfusion reaction, so you're not giving too much at one time.
Is it?
Yes. Go ahead.
Oh no, I was gonna state 125 ml per hour, but it's for the something else. It's not it. I can't find the rate.
So, per your book, it says start the blood at 2 milliliters per minute, which comes out to how many per hour?
120.
Okay, so that's one facility protocol. A different one, which I'm more used to, is 25. So you start at 25. So we'll start it at 25, and we'll see how the patient reacts. If no reactions occur, we can bump it up after 15 minutes to the
To the
rate that's in
125?
the orders. To the 125.
Okay.
Yes.
So imagine we have a question like this on the quiz. Are we gonna be putting 25 milliliters per hour or 120 milliliters per hour?
So
2 milliliters per minute.
we'll go by the book. 120 milliliters per hour to start.
Okay.
But just note that each facility is different, and most likely because there are facility differences, you're not gonna get a question like that.
Okay, cool.
Are we only gonna run it like that for 30 minutes first, initially?
15.
Oh, okay.
15, and then you can increase the rate.
For 30 and then an hour and then an hour? Or not
After
necessarily?
15, you can increase the rate, and then after that, you come in just to check vital signs.
Okay.
But don't change the rate.
Okay.
Since Q15, right?
Vital signs, yeah, usually initially it's Q15, then like Q30, Q hours, so you're done. It's only for 4 hours though, so typically you probably get about
4.
Yeah. Well, beginning is 1, 6, 7. This beginning and end. After you end, you have to get more too. Okay, so he's spiking the blood. We are still making sure that the saline is clamped. We have not touched it. Okay.
Am I just okay to stop the patient then?
Yes. Get your alcohol pad. We had already checked the IV's patent, so unless something's really happened to it, it's gonna still stay patent.
Do we flush? Because you know there's air in the IV tube, so what do we?
He primed it earlier with the normal saline.
With the saline?
Yeah, with the saline. But you make a good point, so I'll show you something about priming the tubing again with blood. So he's connected his patient with the to the blood. He's gonna set it at 25 milliliters an hour.
Gotta turn it back on.
So we educate the patient. We're gonna start your blood transfusion very soon. I'm gonna be in here in the room with you for the first 15 minutes. We just monitor per hospital policies, monitor for any transfusion reactions. The likelihood of you getting a transfusion reaction from this unit of blood is very slim. But per safety protocols, with every transfusion reaction, I have to stay with the patient, that case being you right now. If you have any symptoms of back pain, chills,
Genius.
tachycardia, shortness of breath, breathing problems,
Thank you.
Yeah, rashes, hives, itching.
rashes, hives, itching, then please let me know. I'll be here for the first 15 minutes. And throughout the transfusion, I'm gonna come check on you. You have your collar next to you. If I'm not in the room and you're not feeling well, just push the collar.
This side.
More 25. Alright. So open the line with M1. Because I have a rate in the BTBI. But this is still clamped, so
Yes, unclamp the blood. Are we running it?
no, open plug if this says the line's invalid. Come on, work. It's open. Good to go. Perfect.
Okay, so it's running?
Yeah.
Good, so it's currently, does that look good to you, Nicole? 25?
Yes.
Okay, so it's running at 25, both nurses have verified it. Now, typically Nicole's job is done until he calls her over again to change the rate. Josh will have to stay in the room with the patient for the first 15 minutes. When does our 15 minutes start?
Since we started.
We've started the pump.
As soon as the infusion starts.
It's started. Is there 15 minutes starting right now?
When he gets to the session.
When blood gets to the patient in the system. Okay, so look at how fast the blood is running. Okay, it's running, but it's barely running. You would be here probably for the next 8 hours just to wait for the blood to get to the patient. So I'm going to show you guys a trick. So regarding priming the tubing with blood, put this on hold. Okay, go ahead and disconnect the patient from the tubing. From the tubing. Hold it into our sink. Change the rate to 1,000. It's disconnected from the patient. That's the main thing. So 2 big things I look for. Saline is clamped. Okay, and if you're priming the tubing priming the tubing at all with blood or normal saline and you have a very fast rate, you're disconnecting from the patient. So those are just 2 big things I doc students for. So perfect. Now run it. So he's running at 1,000. Okay, so he's running it at 1,000, and you see how fast it's primed now. We don't have all day. We have a patient that needs to go to the bathroom. We have another one that's been calling for pain meds. We have a separate patient whose family is not happy, and so we got to make sure we're not spending like eternity in here. So it's priming. Okay.
That looks really cool.
Trying to clamp it so you don't have 2 bags with them, because then you have to cook both, and it's so much volume.
Can you see the screen?
So they go until it's like the blood's on the edge here.
Because once the blood's on the edge, and then you hook it up back up to the patient, that would be considered your 15 minutes. Then your 15 minutes starts. So big thing to remember, have to unhook the patient when you're priming the line. Before you hook the patient up to the line again, you've changed your rate back, okay? Because you can't run 1,000 milliliters into your patient.
Alright, yeah.
Perfect.
Alright.
So he's changing his rate back to 25.
Hook it up to Mr. Bleeder.
Yes, for that part, does the second nurse have to be present when you're priming the tube with blood? Or
Yeah, she does. Or he does. Because we're changing the rate back. Yeah.
Just pulling out of bed. There we
Perfect.
go.
So hooked back up. Now we're running at 25. Okay. Beautiful, beautiful. So his 15 minutes starts. He's in the room, he's checking for any signs and symptoms of transfusion reactions, and let's say 15 minutes goes by like a breeze. Patient's feeling fine, patient's watching TV, you notice no issues at all, you ask him, do you any shortness of breath, whatnot? No, denies it. So patient tolerated it. After 15 minutes, you can check vital signs again, which is also within normal limits. Okay. And then you can change the rate. So your second nurse comes in again.
I need help.
Okay, what are we changing the rate to?
125.
We can do 125. Why are we setting the rate up to something higher? Why can't we just run it at 25 this whole time?
Oh, it has to be over 3 hours.
Yeah, it has to finish within like 3-4 hours. So at 25, that's way too long. It is a 300 milliliter bag, so we have to make sure that we don't let it expire before we finish running it. Perfect. So it's 125. Nicole has checked him off in the chart. They both sign off, and now you can finally leave. Okay, so he can leave. Then you have to come back in 15 minutes from now. So you can check one patient, get them situated, come back, check on this patient, check vital signs. So it's like, basically vital signs would be baseline before you hang the blood. After the first 15 minutes of blood, 15 minutes from that, and then 30 minutes from that, and then I usually do 30 until the very end. But at the end, some nurses just, if the patient looks fine, they'll check on them within like an hour or so. But initially it's like 15 minutes, 30 minutes, then you get to an hour. Alright, so let's say the blood is done, okay? Some nurses turn this off, flush the line, and then that's it. They disconnect the patient, this all goes into biohazard. Other nurses, a second option, if you want to run the rest of this through, go ahead and clamp up the blood bag, open up the saline, and this is the only other time they'll use the saline. Otherwise, they'll just prime the tubing with the saline, and then the rest of the saline just toss. Honestly, we don't need a big bag like this. Okay. So now the saline's going through, it's diluting it and flushing the rest of it. And then after that's finished, then you can turn this off. Go ahead and turn it off. And then disconnect your patient, flush their IV. So for this patient, when do we have to recheck labs? How long? That depends on,
Oh, I was gonna say, what did you say? PHNH, 2 hours.
good, so after this doctor wants after 2 hours, so basically it was 2 units to start. We hung 1, we have to do the whole thing again for a second unit. Then tell the lab, okay, I finished transfusing 2 units of blood, can you come through all the patients' labs in 2 hours? So it would be the whole process again with a second bag, different tubing and all. So you can see why I don't like blood. It takes a long time. Okay. So that's it. Let's say the patient tolerated the blood. Hopefully later their H&H levels will go up. Okay. Any questions about blood transfusion? Yes.
So if we like decided use the normal saline to clear the rest of the tubing, can we up the rate so that to like will we just keep it in there, or just take the tubing out and just open it?
You just open, you just clamp the blood side and open up the normal saline side, and you keep it at the same speed, because just remember, you are still flushing the rest of the blood through, so you don't want to go too fast.
Okay.
All right. we've given blood. So that was the demo. And next week I'll divide you up into groups and you will know your roles.
Mhm.
There'll be a video test out. Okay. Let's see what you have. Perfect. 9:02. Okay. Do you guys need another break? Okay. Go on your break. When you come back.